Well, Michael, you set us up very nicely in regard to the next topic of evidence-based care. And you introduced this issue of cost. And cost and shared risk is something relatively new to the provider space. We were always very segmented, and cost was the purview of the payer, but not the purview to the large degree of the provider, and also not to a large degree the purview of the patient, who via their payer was covered. And there's been a lot of debate, and we're not getting into debate around that shared risk story, but it exists today. And to some degree, when you have shared financial risk for treatment, it can be seen as in conflict with evidence-based care. So does evidence drive? And if evidence drives, where does cost fit in? So I want you to touch on that next, and tell me how you as a clinician align, and even at a practice level and on a national level, because you're involved with various organizations, how you start to align the cost and evidence, and given the fact, especially with biosimilars, that the evidence is just by nature of the way they've been approved, less robust.
You know, that's a really good question. I remember back in my medical school days, in one of my ethics class, I actually remember this. It's in the AMA Code of Ethics, and it's one of the things that I remembered since then, is that as physicians and healthcare providers, we're ethically obliged to try to make the best use of the resources that we have. And I think that as a society, we are growing to realize that we don't have unlimited resources. And that's something that's always going to be in the back of my mind, by the way. But first of all, you know, one of the things that I do, just because it's part of how we practice medicine, is to make sure that we're giving our patients the best care possible. And that's where evidence-based outcomes, evidence-based care, you know, has evolved. And we learn through clinical trials and studies, you know, what seems to be the most efficacious for our patients. Now, when we have more than one option, and they seem to be equally effective, and there are no unique contraindications for treatments or preferences for treatments based on patients' comorbid medical conditions, the other medical problems they may or may not have, and everything looks like it might be equal, well then, in the big picture of things, I think one of the ways we're starting to approach medicine is, what's the most cost-effective way to try to manage this? And that's an interesting concept for doctors, because most doctors aren't even aware of how much these drugs or medications cost.
No, I think there's also complexity in the cost, right? Is it actual cost, and is it the cost to society, the cost to the practice, the cost to the patient, and out of pocket? And it gets very confusing in terms of payer design, contracting, rebates, contract design, in terms of what that total cost picture is. And there's not a lot of transparency to it. So which makes it even that much more difficult to try to address.
It's layers of complexity upon layers of complexity, because even though you might have two treatments that are equivalent, and one is a third of the cost of the other treatment, but it requires 3 times as many treatments, then where are you at in that mix? You know, and so that's why there's multiple things to take into consideration, and it's not as simple as people would like, and it's just not as simple as looking at the flat drug cost. We're trying to look at the total cost of care. And so given in unique situations where you have something like a biosimilar and a reference product, where they have the same protocols, the same number of visits, it makes it a little bit easier in this scenario to say, well, if the biosimilar is approved for the same indications as the reference product, for the same indications which I'm going to be treating a patient, and it is of a lower cost, then, you know, that's where you have a discussion with the patient and you let them know why you're recommending it, know why, with the explaining the evidence behind the rationale, not just the fact that it costs less. Also explain to the patient that it's been demonstrated to be non-inferior, and for all that we know and all that we've seen, it looks like it should work just as well. Usually patients are getting to be more and more inclined to say, yeah, that sounds like a reasonable option. That's something that I would like to try.